Hello and welcome to this special edition of Cystic Fibrosis Review. I'm Peter Mogayzel, and I'm joined today by Dr. André Cantin, who's professor in the Department of Respiratory Medicine at Sherbrooke University in Sherbrooke, Canada. We're recording this interview at the 36th Annual European Cystic Fibrosis Society Conference in Lisbon, Portugal. Welcome.
Thank you.
I wanted to start by asking you about biomarkers and what they are and how they're used in cystic fibrosis and why it's important to identify them.
Right. As you know, these are exciting times for cystic fibrosis. There's a lot of research that's now leading to clinical applications. Mm-hmm. A lot of new drugs, new therapies, new approaches for patients. But to try to find out quickly and well if your patients are doing better with these new approaches, it's necessary to have some surrogate markers. And so we're looking at biomarkers mainly to find out how the patients will respond to new therapies. Mm-hmm. We're hoping that we will be able to make the correlation between the biomarker and patient outcomes that are meaningful clinically. And the advantage of a biomarker is that you get the information much more quickly, and then you can hopefully predict what the response will be.
Okay. How do you go about looking for biomarkers?
Well, we're very interested in the lung disease. The lung, of course, is the organ that causes the most difficulty and the most morbidity, and is the cause of mortality in patients with cystic fibrosis. And it's a very highly inflammatory disease in response to the infection. So we're looking at markers that would reflect the inflammatory response and also might reflect the lead into bronchiectasis, which is the cause of respiratory insufficiency. So we divide it up into three categories. We're looking at acute phase reactants, cytokines, and one very special category, which is neutrophil products, since it's a very heavily neutrophil-dominated disease in the airways. And for we had to hone down on our markers because there are many that you can look at. And what we did is we looked at the acute phase reactants, looking at sialic acid, which is a sugar that's found on many of these acute phase proteins. So you get all your acute phase reactants there. We did an array for the cytokines, so just to screen. And we focused on the neutrophil biomarkers, mostly on elastase, after looking at some others, so neutrophil elastase.
Are the biomarkers you're describing in the lung, or are they in the blood?
They're derived, many of them are derived from the lung. The neutrophil biomarkers are derived directly from the lung. But you can measure them in the blood. The cytokines are also produced locally and systemically, as well as acute phase reactants are produced systemically. But the blood is, we thought, was a very good place to look for biomarkers because every person who's in a study or every patient that we see in the clinic can give blood, contrary to more invasive techniques.
And were there particular markers that you found predictive of lung function or a decline in lung function?
There were actually in all of our studies the best marker that we found was the neutrophil elastase, which in the blood is not free. It's complex to alpha-1 antitrypsin because the neutrophil elastase in the lung is free, crosses into the blood, and then will combine and be inactivated by blood alpha-1 antitrypsin. So what we do is measure the complex, and this has been a test that's been known to be somewhat reflective of lung disease and CF for over 20 years now. The novelty is that we tried to compare it to other biomarkers and to see if it tracked with lung function and exacerbations as well as response to therapy.
Did you identify biomarkers that could be used for identifying exacerbations or predicting effective therapy for exacerbations?
Yes, we did. Actually, the best biomarker that we found were the neutrophil products, and especially the neutrophil elastase alpha-1 antitrypsin complex. So that really increases markedly during exacerbations. And what's interesting is that all patients who had 2 weeks antibiotic therapy for an exacerbation had their biomarker neutrophil elastase return to normal. Actually, they returned lower than their levels when they were stable. So they returned to the levels that we could find in healthy people at the end of an antibiotic treatment.
And did that correlate with their improvement in lung function?
It did. It actually did. And the other interesting thing is even when they were stable, not during an exacerbation, you could get a good correlation between the lung function during a stable period and the amount of neutrophil elastase. So it seems to be a marker for lung function and a very good marker for exacerbations and response to therapy.
How do you envision that these will be used clinically in the future?
Well, I think that biomarkers have their limits, and I think even the best biomarker will not be sufficient for a study, so it will need to be combined with other clinically meaningful endpoints. But I think that this neutrophil elastase could be a much more broadly used biomarker in clinical studies. I think it's telling us something. It's minimally invasive to obtain, and it will be, I think, very helpful to get early hypotheses on different therapies that we're using.
So thank you very much for joining me and talking about your work on biomarkers for cystic fibrosis. And thank you for joining me for this special edition of eCystic Fibrosis Review.